I have a little bit of a difficult task, I think, because we just got done talking about a lot of, I think, sexy things, right? Marketing, direct access, social media, and it was all wonderful stuff. And I'm going to start talking about Medicare, right? Everybody's favorite subject. And I specifically we're going to talk about bundled care payment plans, and even if the stuff that I'm going to talk about doesn't affect you and your practice immediately, I can nearly guarantee you that it will in the near future if you treat Medicare patients. And I can even guarantee you that it's going to affect you directly if you don't treat Medicare patients, because other payers are copying what Medicare does again, right? There are other payers getting into similar bundled care payment models, and I think you're going to see the pace of this whole thing accelerate, right? So it's a big deal, and I think there's implications in this for the other things we were talking about, like direct access, even, and I'll try to weave those things together. Hit the button. There it is. So I want to talk about these two big Medicare programs. I'm not going to spend very much time at all on the first one, the second one, BPCI. So we're going to talk about CJR. What is it? What's that mean? What's that mean to me in my practice? How does it work? Are they important? You've already given me the answer. Yes, I think they're critically important for you to understand. I really think it's important for us to look at the incentives that Medicare is putting in front of us here because they tell a message. And then finally, we're going to talk about some practical implications for actually participating in the CJR program, right? And how you need to start thinking about preparing for that right away. Okay? So, CMS has two major bundled care programs. I don't think this slide's in your deck, or it might be, and I apologize, I threw some extra slides in and rearranged some things just to keep you flipping pages. So. There's two, the comprehensive care for joint replacement model, right? And bundled payments for care improvement initiative. Gotta love that name. Bundled payments for care improvement initiative, right? And all the information, there's reams and reams and reams of information about both these programs on the CMS website. You go to the Innovation Center. So if you go to CMS Innovation Center, you're going to see this, and you're going to see a lot of other programs they're thinking about that should scare you a little bit, okay? But these are the two that are kind of close to us. The Bundled Payments for Care Improvement Initiative, I'm not going to talk too much about, this is going to be about it. There are 4 different types of BPCI programs, all different bundled payment types. Some of them are just for the hospital stay, or some are for the hospital and post-acute care, all sorts of variations. But the BPCI is voluntary, right? These are both hospital bundled programs, but BPCI voluntary. Hospitals actually raise their hand and sign up and say, I want to do the BPCI, it sounds wonderful, it's going to be great, right? CJR is not, right? And we're going to talk some more about that. There's a really good article, or an article written by Justin Moore in February 2016 issue of the APTA Journal called Unpacking Payment Bundles. And I would urge you to go read it because it gives you a kind of good background on how these things, or how to think about these things. But I thought it was really interesting, if you just take the key words out of his main bullet points here, right? That's what I think you really need to start thinking about. Need to have standardized data collection. Clinical practice guidelines need to be integrated into our systems. Need to start thinking about team-based care. When he says team-based care, I think he means working across our healthcare silos, right? Right now, we're pretty isolated, right? Most of us are in freestanding outpatient PT and OT clinics, right? Don't have a lot of interaction and communication with people in skilled nursing, right? Or home health. So we need to think through that a little bit better. And then we need to understand our costs. Interestingly, cost accounting in healthcare is one of the most difficult things for people to track. It's really, really hard, right? Clinical outcomes are relatively easy in comparison. That's hard enough, right? But we need to start thinking about those things at a high level. So, CJR. I love this next slide. This is actual language from the CJR program on the CMS website. Because when they first announced the program, some of you may remember we were saying CCJR, because the title of it's the Comprehensive Care for Joint Replacement Program. So people coined the acronym CCJR. And I started Googling CCJR, right? And they actually put, no, we've changed the acronym because we're going to be so darned efficient, we're going to drop a C, right? So the acronym, the official acronym, the blessed acronym for this program is now CJR. It's in the Federal Register. You can look it up, right? I thought, now that is, that probably took a half a day for someone to figure that out. As I said, it's a mandatory, yes. Did someone say it? Or was that an echo? Echo, okay. It's a mandatory program. It's a hospital program, okay? It's in 67 metropolitan statistical areas across the United States, which are these red places on the map, right? Mostly larger, right, metropolitan areas. Really interesting. Oops, just want to point out right here. That's Salt Lake City. Salt Lake City, for whatever reason, is not covered, but the areas north and south of Salt Lake City are covered, right? Weird. All sorts of things. Nobody in Alaska or Hawaii, but you see it does affect those of us here in the Seattle metropolitan area, right, and Portland area, Southern Oregon.
Are these university hospitals? Is that why?
No, these are all hospitals. All hospitals in those areas who do Medicare, right? So essentially all general acute care hospitals, okay? That represents about 800 hospitals nationwide and 23%, almost a quarter of the hip and knee joint replacements that are done. So it's huge. And this is right out of the gate. This program was just being talked about early in 2015. At least that's the first I heard about it, right? It wasn't even finalized until November of 2015. It was effective April 1. Huge, very, very fast implementation of a massive program, right? What is weird, a little bit weird, and we'll see how this shakes out, is hospitals outside these red areas can participate voluntarily if they want to. They may look at the incentives and say, oh, this looks like a pretty good deal. I'm going to write CMS and say, hey, we want to play too. So even if you're not in one of these areas, it might affect you more than you know, right? Interesting stuff. So here's a little bit how it works. Everybody's going to get paid the same. So that's why it kind of happened. It happened April 1st. It may be affecting you, but you're not really noticing anything because there's no change in initial payments, right? Hospitals are continuing to get paid the way hospitals get paid. Post-acute providers, skilled nursing, home health, freestanding outpatient PT, we all get paid the same way we always get paid, right? So nothing much happens. But the hospital has a target price that they're held accountable for, okay? And it's based on historical data. Everybody with me so far? And they're going to start tracking, this is critical, sorry, back up. They're going to start tracking costs from hospital admission through 90 days discharge. Okay? They're going to discount this target price to the hospital. In other words, they're not going to pay the hospital the target price right up front. They're going to pay the hospital a discounted target price, anywhere between 1.5% to 3%, based on, and the rate of the discount is going to be based on what CMS calls quality measures, which I purposely put in quotes, because we're going to talk about quality measures and what they mean to us. Everybody good so far? Okay, the three components of the quality measure are complication rates, which would be like infections, hardware failures, readmissions. A patient experience survey called the NQF 0166, which is you should read it, it's kind of humorous. It's all about the patient hospital experience. Was the nurse nice? Was your room clean? Did they answer your call bell? Right? So it's really a patient satisfaction survey for the hospital experience. Yeah?
That 1.5 to 3%, is that on top of the 2% sequestration?
Yes.
On top of it,
Yes.
not removing it?
No, doesn't remove the sequestration. And then patient-reported outcomes, the stuff that's important to me and you, how much better did the patient actually function after all this, is a piece of this. But it's a little disappointing, right? Here's what the quality measures look like. There's this elaborate scoring mechanism, as only our government can do, right? 50% of the score is based on this complication rate. You can see some of the things that make up that complication rate. You know, did they get pneumonia within 7 days? Did they have a MI within 7 days? Those sorts of things. And then the patient experience survey I already talked about is 40%, so this basic patient satisfaction survey is a big component of the quality. But look at this, patient-reported outcomes, the stuff that we think is important, it's only 10% of this, right? So it's not, I maintain that really the important thing is the least weighted thing here, right? Really getting the patient the outcomes that they deserve, which is unfortunate. And then this is the way, and it's, not to belabor all of this, but based upon the hospital's quality score, those three components, if you get below a 4, then you're below acceptable, and they're going to discount you the whole 3%. And that's going to cost you about $1,000 a case. That's very rough nationwide based upon a number of factors. These are just very rough estimates, okay? Just ballparks. If you're above 13.2 on this quality scoring mechanism that I just talked about, and you get an excellent rating, then they're not going to discount you as much. So the approximate discount on the target rate is going to be about $500, okay? What a country. What a country. This is just great. And if you're below acceptable, then you're not eligible for something we call gain share, which we'll talk about. So the way it works is we're going to discount you, hospital, right? And we're going to give you a reward if your costs are below target, and we're going to give you a penalty if your costs are above target. Okay? Pardon me?
What was the reward?
The reward's a reconciliation payment that I'm going to talk about. There it is. So the reward might look something like this, right? They say, we will give you a certain portion of savings, and this, again, is rough, but according to articles I've read, these are ballpark figures for what the potential reconciliation payment might be, right? So later years of the program, years 4 and 5, you can get up to like $4,400, right? Back to the hospital. Okay? How's everybody like it so far?
So strictly just off of how the cost of the care is provided.
Yes. So it's all about cost, right? Yeah.
It's mainly be nice and don't die, don't get infections, and you'll be okay. This has nothing to do with physical therapy.
So correct. So the comment was this is all about post-op complications and whether or not people died, and has very little to do with physical therapy, and I agree. So far, I agree. Then just to round it out, hospitals are free to what's called gain share, which is a new word I learned a couple months ago. Gain share, love it, right? Which means they can spread the reconciliation payment out to other people they collaborate with. which includes you, which includes us. Okay? There are actually this whole series of exceptions to anti-kickback statutes, that sort of thing, right? Because doesn't this look like a kickback, right? So there's like these waivers against anti-kickback laws that are incorporated into the CJR thing. It's just awesome, right? So a little story about this. I mean, I first started hearing about this early last year because our CEO Rick was called, and he said, I think it was the Washington Post or something, some big newspaper said, Mr. Young, we understand you're involved in the physical therapy industry. What do you think about the comprehensive care for joint replacement program? And Rick did a little preliminary research on it because it was brand new. And from what Rick read, he was very excited, right? He calls me up, he says, hey, Jerry, hear about this CCJR thing? It's going to be awesome because it's going to reward physical therapists for doing what they do really well, right? Which is getting people better quicker, you know, decreasing hospital length of stay, decreasing post-op complications, improving function. I said, sounds great. He said, dig into it a little, will you? So I dug, and I dug, and I dug, right? And I called him in about a couple weeks later, and I said, I think this thing sucks. This is horrible. This is the most poorly designed thing I've ever seen, right? I don't see, this is nothing but bad news for PT. That was my initial take on this whole thing. I see every incentive for hospitals to make sure that people get no PT after discharge. That's all I'm seeing here, right? So I endeavored to kind of look at the incentives here and see if there's some things we can do to turn the table, right? So what CMS said was that they have all kinds of reasons for doing this, which are really interesting, right? It's the most common elective inpatient hospital surgery done today, nationwide. There is a huge cost. That's just hospital costs, $7 billion just in hospital costs to CMS a year. Huge number, right? And the variance in costs, hospital to hospital to hospital, are also huge, right? I think it's Puerto Rico is $16,500. If you want to get your knee done in Puerto Rico, it's the cheapest place. And I think $33,000, probably no surprise, is Florida, somewhere in Florida, right? And there's all these places in between. And Seattle and Portland are kind of in the mid-range, $22,000, $23,000, something like that, right? And the variance in quality based on complication measures varies by a factor of 3, right? So in some hospitals, your chances of getting an MI or a post-op infection or something else bad happening to you after one of these surgeries, and it just varies a lot, right? So Medicare looks at this and says, you know, there's something that should be done about this. So as usual with Medicare, their motivation is always right. I mean, they're always trying to do the right thing. Their implementation is clumsy and bureaucratic, yeah.
What does it matter what hospitals charge when you have to follow their fee schedule?
Because the fee, my understanding is, and I'm not a scholar on DRGs, right? But DRG payments do vary regionally based upon hospitals' prior costs. So it's not as universal of a fee schedule as it is for us in the fee-for-service world. But yeah, CMS definitely pays more out of pocket in some MSAs than others.
Even simple things like MRIs and CAT scans vary greatly
Absolutely.
depending on where you get them.
Yeah.
Right, but if you're contracted, you have to follow their fee schedule, and Medicare's gonna pay a cap of whatever.
In the fee-for-service world, yeah, I think in the fee-for-service world that's true. In the hospital world, not quite the same thing. Yeah. So their goals are, they think they're going to save $250 million in this program, right? And reduce the quality variance and improve provider collaboration. That last part I think is really kind of interesting, right? So, anybody recognize this picture besides me? No one? No one from Portland?
Looks like Portland, up on the hill.
Yeah, it's OHSU. It's the sky bridge between OHSU, the big university hospital in Portland, and the VA hospital. I have paced up and down that hallway miles and miles and miles. So, I think the way forward is pretty clear. I think they're giving us a pretty clear message of the way they want to manage post-acute care costs, right? And it doesn't involve putting us in the driver's seat. Okay, it just doesn't. So here's why it's different. It's mandatory. It's a bundled hospital payment, right? Professional payments are kind of done the same way they've always been done. So it's this kind of odd hybrid, right? Discounted bundled payment to the hospital, but fee-for-service payments for everybody else, and this reconciliation thing that happens, very complicated. The gain share thing, right? It's the first time I've ever, in my memory, that we've had programs where you can get a kicker, right? You get some sort of reconciliation from the hospital, right? Potentially. And this whole thing of reducing post-acute care costs. So it looks something like this, right? Hospital gets the payment for the DRG. The physician, the hospital, outpatient PT department, if they're doing the outpatient therapy, skilled nursing facility, home health, and freestanding outpatient PT and OT, right? They would get the same fee-for-service payments they've always gotten, right? Medicare is going to track all those costs across all those providers, across all those silos, right? And they're going to compile it for the hospital experience plus 90 days post-discharge. Okay? So the episode starts in the hospital when the patient's admitted. It ends 90 days after discharge. And then there's this reconciliation payment. So the question becomes, what can the hospital control? Right? And if you look at this list, they might have some control over readmissions, right? If they do a better job of reducing infections, as an example. They may have some say in where the patient's post-discharge, where the patient's admitted after discharge, rather. Are they going home? Are they going to skilled nursing, inpatient or outpatient, right? Home health, hospital outpatient, outpatient therapy services. Is there something they can do about drugs? There's only so many things that are in their control here, right? Theoretically, none of this is supposed to be in the hospital's control. But I learned a new word last week, new term, soft steerage. We're not really steering the patient. We're not really telling them where to go, because we can't do that. As a patient, you have a choice of going wherever you need to go to get the best care, right? But we're going to just subtly suggest, right, that maybe you come and see our therapist in the hospital. Yeah?
Does the patient fill out that questionnaire, the patient satisfaction questionnaire after the 90 days, or during each part of their 90 day?
It's a mailed questionnaire, sometime way after the discharge.
After 90 days?
I'm not sure about the after 90 days, but it's going to be after the discharge. I know that.
So it would include their experience after they left the hospital
No.
before 90 days is up?
No, the questionnaire itself is all about the hospital experience. It's not about anything else. It's specifically, like I say, was the hospital clean? Was the nurse nice? Did the physician come? It's all about the hospital experience.
Not asking about the skilled nursing. So then what do they care where they send the patient back?
Why do you think they care where they send the patient?
I thought that's what you were getting at here, that they're trying to control where the...
Exactly. Yeah. So is it more, remember the hospital is now going to be worried about the post-acute care costs. They've never been worried about them before, right? They're going to want to make sure that they send patients to a good quality, low cost post-acute provider, right?
Because they're only getting a certain
Right.
And on top of that, they might be discounted a certain amount of dollars. way down the
Exactly.
road.
Yeah. Hospitals trying to avoid a penalty for those costs and or get maybe a little reward for controlling the costs. This is an interesting article to me. Innovative models such as CJR offer PTs opportunities for less fragmented patient care, greater freedom to design care to meet best practices, expanded practice, increased interdisciplinary teamwork, right? I love the next sentence. These opportunities bring challenges as well. Well, no kidding, right? No kidding. Huge challenges. But I do think there's some opportunities here. This is official language from the consumer fact sheet, right? So this is CMS telling our patients, you have every right in the world to choose any provider that you want to choose. But then they're turning around to the hospitals and saying, it's okay to provide incentives to steer patients to people, you know, that you want them to go see, right? Interesting. So, does anyone know if you live in one of these CJR areas, if you practice in one of these CJR areas, do you know if it's had any effect on your practice at all? Anybody? You think it has? Enumclaw? And what have you noticed, Rick?
Well, the hospital there sold a couple of years ago, a hospital group.
Uh-huh.
And they are.
I will.
They are steering soft steering the rehab patients to City, Diamond, Black Diamond.
Right, right. So hospital took over a local physician group. This is a story we hear all the time, right? And all of a sudden, more patients in general are seeing are being steered to the hospital outpatient PT, right? But you don't know, you haven't seen any, you haven't noticed any effects of the CJR program since it's instituted in April 1. This sounds like it's something that already happened.
No,
Right?
yeah.
Yeah,
Absolutely, this has been going on for a couple of years.
yeah, absolutely.
It's in line with what you're talking about.
Yeah. Yes.
I work in a nursing home near Tacoma that we're in the area, and the company I work for is attempting to do two things. One, somehow link themselves with a home health provider so that they can sort of crony up,
Mm-hmm.
become sort of a continuous system. And two, instead of your typical 90-day to 100-day Med-A stay, they're trying to get it down to a 10 to 20-day stay.
Yeah.
Before they just, so that just the bare minimum to get them home and then discharge them home.
So I'll repeat what you said, and I'll paraphrase it a little bit. But so currently works in a skilled nursing facility, right? There is a program at this facility to cooperate with a home health agency and try to decrease that inpatient skilled nursing stay and get those patients in home health a lot more quickly, right? I think you're going to see, so it's having an intended effect, right? It's people, so this home health agency and this skilled nursing facility probably never really talked to one another before. Now they're talking, so that's maybe a good thing, right? But we need to get ourselves in that conversation as well. So, and as I mentioned before, I think we have a big problem, and not just with CJR, but in a number of other areas, we are so isolated, right? The average PT clinic in this country, I think it's, I forget the number. I don't know if you remember, Jim, but I think it's like 60% of the PT facilities in this country are 4 therapists or less, right? Which it wasn't really a surprise to me, but it's, you know, if you're a provider and you have 15 therapists, you're big, right? We're very isolated. We don't have good, seamless methods of communicating with other people in the healthcare continuum, right? Which is a problem. We need to overcome it. Okay? So, how do we adapt to this, right? Here's what it looked like from the hospital's perspective prior to April 1. Grumpy old guy comes in, he's got a bad hip. We have surgery. We discharge him. far as the hospital is concerned, he's a happy camper. We're not worried about him any longer. He goes away. Maybe we'll get his other hip in a couple of years. You know, other than that, not at all worried about them. Today it looks more like this, right? Beginning April 1. We go through that same, now the hospital's worried about what that orthopedic physician is going to do, right? Is he going to send them off to a really expensive skilled nursing facility, right? Is the skilled nursing facility, do they have their own outpatient center? So they're going to refer, a patient gets maybe discharged from kind of the acute portion of the skilled nursing stay, and then they discharge them to their own outpatient facility or to home health. Does he go to the hospital? Are they steered to the hospital outpatient department? I think that's going to happen quite a bit in this model, right? Worse yet, do they get no rehab at all? That's happening a lot, right? A lot of people, especially with hips, yeah.
Yeah, that's another thing I've seen, another colleague of mine in one of the other areas in another state. He said he met with one of the orthopedic surgeons and looked at their new joint program, and it didn't include PT at all.
Right.
It was just an expense
Oops,
they could
sorry.
completely cut out.
Yeah, yeah. I'm seeing that reaction a lot. So just to reiterate, so we're seeing a lot of care plans that don't involve PT at all, right? From their perspective, in some ways, PT is the easiest thing to cut out. So we've got to think about getting creative about what we do that. We want this pathway right here, right? We've got to make a case that that pathway is the best for everyone concerned, the hospital, the patient, everybody. So again, here's how it might work, right? A patient might be in skilled nursing for a week or two. They might go to home health for a few weeks. Maybe they get to outpatient PT, probably not, right? All those costs are tracked by Medicare for that first 90 days after discharge, and that reconciliation payment goes back. So we need to think about a new model, a new post-acute treatment model, right? That aligns the incentives of the hospital with us. Somehow, some way, right? Need to get a little creative. So here's what I'm thinking about, is in our new post-acute model, we'd have outpatient PT visits, at least to a limited extent, right? Maybe starting a week and a half after discharge, something like that, after the patient's able to, you know, depending, of course, on the health of the patient. But there's nothing keeping us from doing a home visit, right? As an outpatient Part B provider, you can visit the patient in their home. And you're a hell of a lot less expensive than home health physical therapy. Okay? Now, is it great financially to have a bunch of therapists running, but you don't get paid for travel, right? So is it a wonderful thing financially to have therapists hopping in their cars and running off and seeing patients? No, but if you could do it on a very limited basis and just get that patient going with a good home program here, and then graduate them to your outpatient facility, that's still going to be cheaper than skilled nursing or home health, right? Provided the patient's medically stable enough and all that other good stuff, right? There's some patients that aren't going to fit this model. Make sense so far? Yes?
I don't think that our standing with Medicare, the standard one that allows us to be a Part B provider, allows us to do home visits.
Yeah, it does.
You can. You just have to go.
Yeah. So the comment was Penny didn't think we were allowed to see patients in the home. We absolutely are. Incontrovertibly are. So, which is good and bad, right? Yeah.
You can't do it if they have any other skilled nursing in the home at that time.
Yeah. Good point. So one of the points of confusion is if the patient has an active home health plan of care, you can't do anything, right? You can't see them as an outpatient. You can't see them at their home. You can't get paid for doing anything. It's a mess, right? And a lot of times I understand those discharges don't really happen as quickly as they should. So you need to make sure that patient doesn't have an open home health plan of care. Then you're messed up. Yeah. So I think that's probably what you're thinking of, Penny. Okay? What about supplementing this, right? especially for total hips, gotta say, you know, if I can just monitor them somehow and make sure they're doing their exercises and make sure they're getting more active, how much do I really need to see them, right? So I think supplementing this and getting a little creative about really engaging with that patient, really being proactive, making sure that patient has a reminder about their exercises, right? And the patient thinks that you're actually monitoring them, or maybe you are actually monitoring them through some technology. This could go a long way, along with the home, the very limited home visits, right, to give us a tool to go to an orthopedic physician and say, hey, look, we're all about helping you out with this, right? We'll see the patient once or twice at home, right? So you don't have to send them to home health because you know it's going to be more expensive to send them to home health than it is to me, right? I'm going to get my fee-for-service patient payment for this home visit. It's not going to be terribly profitable because I got to do this travel, but just got to kind of eat it. And I'm going to be really aware of how much outpatient therapy we're doing. We're going to justify it. And we're going to supplement that with some other things we can do to decrease the costs. Make sense so far? Okay, so we're working on some technology that will enable us to do that sort of thing, right? The other key point about this is we're going to be completely transparent, Mr. Hospital and Dr. Smith, right? You're going to know what our costs are because we're going to track them, and you're going to tell, and you're going to see if there is a problem with this patient's care, we're going to tell you right away, right? So we're going to reassure them that we're going to be really responsible, right, in taking bearing a bigger responsibility in this post-acute care model. Okay? Great. This is what I'm even more excited about. This is what Rick alluded to yesterday. Prehab treatment model, right? What's the cool thing about prehab? There's a couple cool things. One of the cool things is that it's been shown to have a really huge benefit to patients. Intensive prehab, right? It decreases post-surgical care costs. And there's some numbers that tell you exactly how much it decreases those costs, right? And, you know, the wonderful thing about this, it's in the Journal of Bone and Joint Surgery. It's not in the APTA journal, right? A powerful tool to take, I mean, that's their Bible, right? Show them that study. Help you sell it. This is another article. This was, I forget where it was at actually, but another study just showing, you know, great benefits of preoperative exercise on functional status. And the most important bullet is the final one. It included a substantial reduction in the need to discharge patients to a rehab facility for both hips and knees. Right? So if we can decrease length of stay, decrease complications, get people in a low-cost provider, and we're really managing those post-acute care rehab costs, then great. So here's the prehab selling points. We have evidence. Decreases length of stay, decreases complications. The beautiful thing about this is this bullet right here. Those costs don't count against that target price. It's a double bonus. Okay? So we can get our fee-for-service business, prehab, you know, and I think that really being an ally with the surgeon, right, and really getting that patient prepared for surgery, it's scary to them, right? They've heard all kinds of horror stories from their neighbor across the street about their total knee. And people love to tell other people how grisly and awful it was, right? It's like women who've had babies. They just love to talk about their labor. So you can read the rest of the bullet points, but I think there's a lot of good points we can make. So here's what that post-acute model looked like, right? Limited home visits, technology-enabled post-op rehab, limited outpatient visits, right? And by the way, even if you saw the patient 3 times a week for 4 weeks or 6 weeks in your facility, you're still cheaper than home health. You're still cheaper than skilled nursing, right? So I'm not saying you have to cut it to the bone. The new prehab model looks something like this. And the big things, I think, are we're going to start that patient engagement process like right away, right? Patient's going to be set up with, here's our program, here's what to expect. We're going to feed that patient bite-sized pieces of information through the entire prehab process, right? And we're going to make one home visit at the end, right? Why are we making that home visit at the end? We're going to set them up for success after surgery, right? After they're discharged. We're going to get them, if there's technology we're going to set up or something like that in their home, we're going to do that as part of that visit. We're going to get fee for service for doing that. Does that make sense? So, prehab looks like this. We have that single home visit. Patient should be super comfortable going into surgery. They know exactly what to expect. They have a relationship with you now. They're not going to go anywhere else after they're discharged. They're going to come back and see you. We will have a clinical portal, right? So that physicians can see, the orthopedic physicians can be assured that they know what's going on. When you put both those things together, they look something like this. And when you look at the entire picture, it looks something like this. And I think, again, the big pieces here are this communication piece. So this guy and this guy can be assured that we're doing the right thing, right? And we're being responsible. So a little bit about that technology layer we were talking about. I think the patient engagement piece is critical. We are looking at many of them, and we want to find kind of the best in breed of those things. It's a way to engage the patient and keep them engaged throughout the entire prehab and post-acute rehab process. I think it's really, you think of what we at least I used to do. I used to hand people just big reams of paper stuff, right? Here's a bunch of stuff, for you. And I don't think that works very well. I think if you can say, here's a little bit of information, you're going to be getting a little bit more tomorrow, and a little bit more maybe in a couple days, right? And we're just going to feed that patient bite-sized pieces of information that they can easily digest, right, at home. And a way for them to easily communicate with you, right, as part of that patient engagement piece. Being able to somehow monitor whether or not that patient is actually doing their exercises, not relying on patient self-report, right? I know you said you did them. I mean, we've all done this, right? Have you been doing your exercises? Oh yeah, every day. Okay, show me. Yeah, I want to see this, right? And they can't, they haven't, right? That's the test, right? There's some technology that will allow us to tell whether or not they did the exercises, right? Not only whether or not they did them, whether or not they did them okay, did them at least at a minimally acceptable level, okay? Which we're really interested in. So the other big piece of this is I don't think that anybody, that our typical client, freestanding outpatient PT clinic, 4 therapists or less, in one of those MSAs, I don't think you can knock on the door at the hospital and get anyone to answer it, right? They're just not, you're not going to even get to the table to talk to them, right? If we can network together, right, and you can get in co-opetition, also another new word I learned, co-opetition, with a network of other physical therapists, and you can agree to a certain way that you're going to handle this. We're going to develop a program with a capital P, a product rather, with a capital P. Here's our CJR product, right? you can have something to hand to that hospital administrator and to the orthopedic surgeon, right, and to your patients to explain all of this, and you actually have systems and processes in place to manage all this. I think it's a tall order. It's going to be difficult, right? But I think that there's tremendous upside downstream, because this isn't the end, right, of these new treatment models. This is just the beginning. Medicare, if this even begins to look remotely successful, it's going to spread across the country. You can bet on it, right? And they're going to say, that worked so well on total hips and knees, we're going to do it for name a condition, right? MIs. So it's going to be a bigger deal. I think it's a huge opportunity. Just to sum it up, we need to collaborate better than we've ever done before, right? We need to break down some silos. We need to team up. We need to be able to manage our patients remotely better than we've ever done it before, I think, right? Communicate. You cannot communicate enough developing a model like this, because we're breaking down a lot of walls that have been up for a long, long time in a program like this. Think about the incentives and how you can differentiate yourself and the rest of us in the process, right? Big opportunity. And, you know, some things we should be doing anyway, I think, right? I think we should be using evidence-based guidelines more than we do. I think we all know that. I think the problem is we don't seamlessly integrate those into our workflow. Another discussion. Really proactively manage cases. One of the things I ask people is, how many active patients per therapist do you have? Right? I think that's an important metric, and it's going to become more important as we get into these managed care, these bundled payment arrangements, right? Because your therapists are going to become more managers and less doers, hopefully. And I think that's a good thing. I want them to be managers. I want them using their brain more, right? How many active patient cases, and I'm telling you, no one can answer the question. The data's there, right? You can look it up in our system really easily, but how many active patient cases do you have right now? It's a great telling question. Financial data, measuring clinical results, tracking costs, and having a defined process. By that I mean having a process for getting a process put together and refining that process over time, a process for developing your processes, right? Big deal. I'm looking at Doug as I say that. It's like, you know, he's all about process. And go. Where am I pointing? There. Okay, so that's me. Thank you again all very much. That was me at 14. I had that's how I got interested in PT. I was tobogganing, and with my buddy who just built a toboggan in shop class. And we decided we would go, our ski hill was closed, so we decided it'd be a great idea to go to the top of this little ski hill, and where I grew up in Idaho, and get on his toboggan. And it was fun for a while. But anyway, my little sister sent me that picture. And just to show you how old I am, that, ladies and gentlemen, is a transistor radio right there. That little thing hanging right there. I was listening to KORT in Grangeville, Idaho. It's the only station we could get, you know. And that was out in our backyard when I was growing up. But anyway, my Twitter handle's @HendersonPDX. I love Twitter. Would love to interact with everyone here in it. I think it's outstanding. We've already heard a lot about that. Thank you very much.